Hello, everyone. My name is Leah Fournier, and this is my coalition presentation for GPH 726, Social and Behavioral Health as a Master of Public Health candidate at the University of New England. First, provide context. For the past 8 weeks, my colleagues and I have been educating ourselves on various socio-behavioral theories, protective and risk factor determinants, and most recently, developing a theoretical intervention program designed to comprehensively motivate individual behaviors towards increasing overall quality of life with the ultimate end goal of bringing about equity for all. I selected HIV as my chosen health condition of concern, given my passion for infectious diseases and epidemiological contagion. Prologue aside, coalition members, please allow me to present to you a design for a social media-based networking program for individuals living within Washington, D.C. city limits that are either at elevated risk of contracting the virus or for individuals currently living with HIV, a platform I've dubbed High Five. Not with any intention of belittling the very real impact this disease has on afflicted persons or their communities, but as a tentative first step towards the impact I wish the service to have. Bringing people together in a safe space to have hard conversations that are used to grow through, with an endless support system behind them as we work towards dissolving stigma and empowering citizens to live their best life, regardless of convoluted medical jargon attached to their patient charts. High Five's ambition is to be support in the palm of your hand at all times. And as 90% of Americans claim smartphone ownership, with a further 2 in 5 reporting cyclical access throughout the day, exclusion sample size is anticipated to be minimal. Time and again throughout my research into this complicated health topic, I discovered the insidious role social and internalized stigma play in calculated life satisfaction for individuals struggling with HIV, and how both types of stigma are interdependent and multi-tiered. Perceptions of isolation and minimized self-worth may be uncompromising barriers to a life of fulfillment and contentedness, but luckily, empowerment and validation are the kryptonite to such negative energies. As people begin to believe that they are in control of their lives, not what happens to them, but how they react, they are able to build themselves back up to a position that everyone deserves, a position of humanity. Because of this, the social cognitive theory and the theory of planned behavior are especially important concepts in controlling what has become an extremely preventable, thankfully also extremely treatable, health malady. While any internet search will tell you there are many behaviors that predispose an individual to HIV contraction, two have stood out as catastrophic contenders of modifiable origin: unprotected sexual intercourse and sharing injection drug paraphernalia. What is further devastating is the way by which these rates are disproportionately affecting LGBTQIA+ individuals and persons of color. In DC, 4 out of 5 newly diagnosed cases are of African American descent. 2/3 are individuals who report other than heterosexual orientation, and only 1 in 4 state they regularly use prophylactics throughout intimate encounters. 41% of these are youth between the ages of 13 and 20. Furthermore, 20% of new cases in the nation's capital are directly attributable to injection drug use. This support will come in 2 primary forms: from peers who have specific lived experience, and clinical professionals, ideally federally funded, who break down scientific documents into digestible information for the general public in multiple languages, as well as provide individually tailored care plans and advice for site users that may otherwise be inaccessible, for example, those without transportation or health insurance. This is designed to be implemented in the most judgment-free forum type possible. Healthy People 2030 suggests 10% measurable reduction in emergence by the end of the 20th decade. I submit, however, that by setting specific parameters for success within targeted neighborhoods and offering gratis support to citizens within, as well as conjoining the right partnerships, resources, and get-go positivity, the power of cohesive community collaboration is criminally underestimated. In addition to keeping the conversational flame lit and providing free of charge education materials for those most heavily affected or in jeopardy of becoming so, I believe it is possible for High Five to minimize other well documented barriers such as food and housing insecurities by incorporating IRB approved financial and sustenance based incentives to participants who choose to opt in for semi annual questionnaires. These would need to be just and equal for all, using the social media platform to ensure maximal practice of preached ideologies. There has been some question as to whether or not it is possible to restrict app access to just BC's 8 wards. However, after some searching, as I am not the most tech savvy person myself, I was able to surmise that through filtering interested participants by topographical locale, only regionally specific IP addresses are to be permitted access, at least until the trial testing period has ended and statistics conclude significant capital efficiency. Thank you for watching, and I hope this has been a worthy investment of time and funds towards stocking technological toolboxes for continuous health betterment.